Hey everyone, my name is Fatima, and in this video, I'll be talking about valvular heart disease, in particular, infective endocarditis and non-infective endocarditis. Starting with infective endocarditis, endocarditis is basically inflammation of the endocardium, and this inflammation is caused by bacterial infection that can involve either one or more heart valves. It can be divided into acute and subacute infective endocarditis. Acute infective endocarditis is caused by high virulence organisms that infect normal valves, whereas subacute infective endocarditis is caused by low virulence organisms, and these infect valves that were previously damaged, for example, by chronic rheumatic heart disease. It is characterized by vegetations along the edges of the heart valves, and these are basically composed of fibrin, platelets, and the infectious organism. So, what is the pathogenesis? In the case of subacute infective endocarditis, you have damaged valvular endothelium that causes the exposure of the subendothelial collagen. This results in the adherence of platelets and formation of the fibrin and can lead to the formation of sterile vegetations. If there is some transient bacteremia, the bacteria can get trapped in these vegetations, leading to the formation of fibrin clots encasing this vegetation, and eventually you get valve destruction with loss of function, for example, regurgitation. For acute infective endocarditis, the main organism that's responsible for it is Streptococcus aureus, and it usually involves the tricuspid valve because it's very common in IV drug abusers. For subacute infective endocarditis, it's mostly Streptococcus viridans, but there are other organisms as well. For example, Staphylococcus epidermidis can cause endocarditis and very often causes endocarditis of prosthetic heart valves. The heart-like organisms cause endocarditis with negative blood cultures, and Streptococcus bovis causes endocarditis in patients with underlying colorectal carcinoma. In terms of complications, if you're talking about the heart, you usually have damage to the valves. But you can also have arrhythmias if there is some perivalvular abscess. And if you're talking about extracardiac complications, then it's usually because of the septic thromboemboli. And first of all, these can occlude vessels leading to infarctions, but because they also have the infectious organism within them, it can lead to infections of other organs as well as the formation of immune complexes. So I just included this picture to show you what the vegetations look like. This is an example of subacute infective endocarditis. And here you can see the vegetations, which are relatively smaller, and they are present all along the lines of the closure of the valve leaflets. So the clinical features can be remembered by the acronym from Jane. So F is for fever, which is obvious because it's caused by bacterial infection. Then you have Roth spots, which are around retinal hemorrhages, Osler nodes, which are painful nodules on the fingers or toes because of the immune complex deposition, which you can see in the left-hand corner right here. You have murmurs because you have vegetations on the heart valves, which disrupts the blood flow. DNV lesions, which can be seen in the upper right corner. These are painless erythematous macules on the palms and soles. And you have anemia of chronic disease because of chronic inflammation, needle bed hemorrhages, which is seen here on the bottom right, the splinter hemorrhages, and emboli, which we talked about in the previous slide, the septic emboli from the vegetations on the walls. Lab findings, there is inflammation, so you would see leukocytosis, increase in inflammatory markers such as CRP, erythrocyte sedimentation rate would be increased. You would see positive blood cultures, except for if the endocarditis is being caused by those heart organisms, like we talked about before. There's anemia of chronic disease, and the lab findings would show that. So there would be increased hepcidin. So you would have microcytic anemia, high ferritin, low total iron binding capacity, low iron, and low percentage saturation of transferrin. Transesophageal echocardiogram is pretty useful for detecting lesions on the walls. The last part is about non-infectious endocarditis. It's also known as non-bacterial thrombotic endocarditis or merantic endocarditis. It is characterized by sterile vegetations on the heart valves, and usually the mitral or the aortic valve is involved. And it arises in association with either a hypercoagulable state or some underlying adenocarcinoma. Again, these arise along the lines of closure. And if, for example, if they involve the mitral valve, they can have regurgitation. A specific type of non-infectious endocarditis is Libman-Sachs endocarditis, and this is associated with systemic lupus erythematosus. Here, the vegetations are sterile and they are present both on the surface and undersurface of the valve. These vegetations are composed of immune complexes, mononuclear cells, thrombi, and the sterile valvular lesions are non-destructive and the vegetations tend to be smaller. Clinical features compared to infective endocarditis, embolization is much more common in non-bacterial thrombotic endocarditis, uh, and this can lead to hemorrhages under the nails, skin, retina. Most affected individuals are usually asymptomatic, however, until obviously the embolization occurs. For diagnosis, you would see blood cultures would be negative and there would be no response to antibiotic treatment because here the endocarditis is not being caused by bacteria. Echocardiography could be useful to visualize valve vegetations, and in biopsy, you would see sterile vegetations on either surface of the valve, so in the upper surface and on the undersurface of the valve. And these would be composed of immune complexes, mononuclear cells, thrombi with fibrin strands. I've included this picture because it like really shows you the differences in how the vegetations look on the valves. So here, the first one is rheumatic heart disease. You can see the vegetations are smaller, almost wart-like, along the lines of closure of the valve leaflets. Here you have infective endocarditis, and you can see the vegetations are much larger and seem more destructive, and they can even progress down into the chordae tendineae. For the non-bacterial thrombotic endocarditis, you can see the lesions are usually small, and again, there are attached along the lines of closure of the valve leaflet, and you can have more than one present. The last one is Lippmann-Sachs endocarditis, and like I mentioned before, you see the vegetations that are present on the surface and on the undersurface of the valve leaflets. And these are the references, and that brings us to the end of the video.